Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Andreas Voss from Regensburg, Germany. Associate Professor Dr. Andreas Voss has specialized in the regenerative therapy of shoulder and elbow pathologies. He currently works at the Sportsorthopaedicum, a highly specialized orthopedic group in Germany. He began his specialized training at the Department of Orthopedic Sports Medicine at the Technical University of Munich, and continued this with a research year in the United States in order to advance the latest findings in joint preservation surgery. After his return, he moved to the University Hospital at Regensburg and devoted himself to clinical and scientific work in the field of complex shoulder and elbow surgery. In addition to his clinical work, he is still very active as a scientist in the areas of shoulder and elbow surgery. For this work, he has already been awarded several national and international awards. So today, it's my great honor to introduce you to Associate Professor Andreas Voss from Regensburg, Germany. Over to Andrea.
Thank you, and thank you for the invitation. And it's my honor and pleasure to share a little bit of my research from the last years, and it's all about the AC joint. So my talk and my presentation today will be about the evolution of the AC joint injury and its treatments. So here is a little overview. So you can see we start first with biomechanics and understanding the AC joint with the right indication at second, and then the new surgical techniques. And finally, I give you a little take-home message. So as an evolution, you always have to look at the anatomy and a little backwards. We all know the anatomy of the AC joint with the conrod ligament, the trapezoid ligament, and the AC capsule. We also know that we have the dynamic stabilization, which are the deltoid and the trapezius muscles, but we also have the static stabilizers, as also mentioned, the AC ligaments and the CC ligaments. It is important to know regarding the function of the AC joint that we have the so-called three corners and three sides. So we have the AC joint, we have the scapula, and we have the SC joint. So on the medial side, we have the core stability, we have the clavicular arch, and in the back we have the scapulo-thoracic tract or scapular tract. All these three corners and all these three sides are very important for the proper function of the AC joint. If we look back in history, it's interesting to know about the development of the human shoulder. As you can see here on the left side, the scapula is more at the lateral side of the thorax compared to the human, where it went backwards on the shoulder girdle. And compared to other animals like the horses, which don't have any clavicle, they only use the shoulder with the pendulum effect of the scapula, and they have a strong periscapular muscular suspension. But they don't have a clavicle because they don't have abduction, as you can see here in this video. So the evolution of the human shoulder girdle basically exists because we have the clavicle. This allows us the force motion over the abduction of 90 degrees because it will work as a strut function. So you can see here, once you reach 90 degrees of abduction, the clavicle and the AC joint will transfer the force towards the thorax. So this is very important to know for the further course of this presentation. We know we have the vertical and the horizontal stability of this joint. The CC ligaments mainly contribute to the vertical stability, as you can see in this here. You can see here the CC ligaments. And the AC ligaments mainly contribute to the horizontal stability. If we look at the combination of horizontal and rotational stability, you can see here on the left, the translation. Again, this one is mostly performed by the AC capsule. And you can see here the rotational range of motion of this little joint, which is sometimes neglected, but it's a very important movement, as you can see here. The more you have the humeral thoracic abduction, the more rotation you have in the AC joint. And this is always also important if you try to treat AC joint injuries or even if you perform surgery. In the history, we have this very well-known study, and we think we know about this. So basically, in the last 10 years, everybody thought that the superior and posterior part of the AC joint mainly contribute to the stability of the AC capsule. So nowadays, we know that there's also a very important part of the anterior and the superior part of the AC capsule. And this is done with this very interesting biomechanical study, exactly studying the rotational appliance of this little joint. And this is done under rotational loading. So this is a specific study about the rotation, and it's shown that the anterior and superior part of the AC capsule are very important to the rotational stability of the joint. So cutting the entire capsule reduced the stability up to 25% during translational testing and 10% during rotational testing. We know that the anterior segments of the scapula of the capsule provide the greatest stability, and the amplitude of the joint's motion significantly increased when AC capsule is dissected. So the AC capsule has a very, very important role during a C joint and shoulder movement. So the evolution part 2 would be the right indication. So which patient do we treat conservatively and which one do we treat operatively? And we know all these classification from Rockwood type 1 to type 6. Basically, everyone agrees that type 1 and type 2 will be handled with no surgery conservatively, and basically type 4 to type 6 will be handled with surgery. If you see here on the right side, this was a questionnaire for 203 German orthopedic surgeons in the year 2012, and you can see here 1 and 2, almost everyone responded non-surgical. As you can see here, Rockwood 3, there is an inconsistency between surgical and non-surgical approach. And when do we treat type 3 AC joint dislocations? So first of all, we need to diagnose a Rockwood type 3 dislocation. And this is a very interesting study about the radiological procedures we have for the AC joint. And so far, when this study was published, 2018, there was no consensus on a gold standard for diagnostic measures regarding the stability or instability of the AC joint. We know there is an inter- and intra-absorber reliability for diagnosing vertical instability of the clavicle using bilateral projection, and they show a high level of reproducibility, while for horizontal instability, the results are more inconsistent. So let me start with a little example. So this is a male patient, 20-year-old, who fell on his right shoulder. And you can see here AC joint dislocation. This is a high-grade dislocation. So this would be a type 5 Rockwood dislocation. Also on the Y view, you can see here the superior migration or the inferior migration of the humeral head. This one would be easy. So this one would be a male 53 years old patient. You can also here see a dislocation in the AC joint, but if you see and use the bilateral Zenker view or panoramic view, you don't see any higher grade dislocation compared to the left healthy shoulder. So this one is not so easy. But if you use a stress view, this is called the Alexander view, you see the overriding of the lateral clavicle, and this will diagnose a horizontal instability. And also in the axial view, we would see a posterior dislocation. So this one is a chronic posterior grade 4 dislocation. And it's always a discussion about weight or no weight. So you can see in the first image here, this is a AC joint dislocation classified as Rockwood type 2, acute 8 days after surgery. And this one here means 5 kilograms. The last means this, they put 5 kilograms on both arms. But 7 weeks after surgery, with no weight, you can see the high-grade dislocation. So the weight bearing or the weight in the acute AC joint dislocation is not recommended anymore, because it lacks the efficiency on unmasking TOSI3, which was by the time the classification before Rockwood. It will unmask grade 5 dislocation, and it also enables a partial to be distinguished from a complete tear. So the recommendation in acute setting is not to put any weights on the shoulder. Also, the axial review is also a very discussed imaging. As you can see here, very posterior dislocation. But if you look at the biomechanical or radiological data we have right now, the standard axial view of the shoulder can mimic a posterior subluxation of the lateral clavicle without having any accident or any trauma to the shoulder, as you can see here in these images. You have a slight posterior dislocation. You also have a slight posterior dislocation in these healthy shoulders. So the axial view might not really help you to diagnose the AC joint dislocation. As you can see here, this is a male patient, 41 years old. And here you can see a posterior dislocation of the clavicle in the axillary view. But once you see the other, the AP view or the scapula, the outlet view, you can see a totally healthy AC joint. So don't be misled by the axillary view with a posterior dislocation. There's even high consensus on radiographs recently published by the ESA, the European Shoulder Associates within the ESSKAs, about the radiological evaluation. So that you can see there's a high consensus on all these images. So the panoramic view, the bilateral Zenke view, is the one which is recommended from this panel. So no additional imaging is needed, such as CT or ultrasound. And it's also clear that no modified Alexander view, just a simple Alexander view, will be used to diagnose the horizontal instability. Also, the ISAKOS consensus, which has been published in 2014, distinguishes the grade 3 from the grade 4, from the 2 and 4. So basically, there's a type 3A and a type 3B. B means there is an instability, the horizontal instability, and type A is with no horizontal instability. So as you can see here, Rockwood 3, persisting pain and scapular dyskinesia, they recommend first conservative treatment. If you can see the cross-body abduction view in the Alexander view, there is an overriding of the distal clavicle. It's a type 3B, and they opt for surgical treatment. If there's no overriding, can continue non-surgical treatment and consider surgery if treatment failed. What's also very important is scapulo-thoracic function, and it's the key to AC joint pathology treatment. So if you look in this study here, there have been 34 patients treated with conservative treatment with chronic AC joint dislocations. That means older than 7 weeks. And they saw that chronic type 3 AC joint dislocation causes scapular dyskinesis in almost over 70%. And also the values for the consent score and the simple shoulder test were lower in patients with dyskinesia. So this is always a point to look at the posterior part of the shoulder girdle and not only be fixed to the AC joint in the front. And as you can see here, this is the reason why we have this scapular dyskinesia. The strut function of the clavicle to the AC joint is this most important function. And you can see here this high-grade AC joint dislocation, which basically leads to a scapular dyskinesia due to these abnormal movements in the thoracothoracic shoulder movement. Because we have all these muscles pulling on the scapula, and if you have a disconnection here on the AC joint, this will be out of the rhythm and cause these problems. So in conclusion, the scapular dyskinesia and the secondary to the chronic type 3 AC joint dislocation can be successfully treated with the rehabilitation protocol. Patients that do not respond to the rehabilitation program will not improve with extensive rehabilitation and might be an option for surgical treatment. A trial of non-operative treatment is warranted because successful outcome can be expected even if patients who basically opt for surgery. patients who presented more than 30 days after the injury were less likely to complete non-operative treatment successfully. So if they do not respond to a physical therapy program within 6 weeks, it is reasonable to consider surgical stabilization of the joint. Part 3 will be the surgical treatments and techniques. And as we know from this study from Knut Beitzler from 2013, we have over 162 variations of AC joint reconstructions. So we have new techniques, technical modifications, and new systems, implants. And this being said, it is clear that there's no gold standard in the technical reconstruction or the technical application of implants, because there are so many different variations. But competing is the driving force for evolution, as Charles Darwin mentioned. Basically, we have these 3 types of different approaches. We have an anatomic reconstruction, we have non-anatomic reconstructions, and we have non-anatomic reconstruction with open reduction and internal fixation. And as we know from the clinical studies we have right now, that we have the best outcomes when using anatomical procedures. So, however, it is very hard to compare all these different techniques because they use different measurements and they do use different implants. So as a shoulder surgeon, a specialized shoulder surgeon, this is the place where we start from. This was a study published in 2008 using this all-suture implant, suspension implant. It was able to anatomically use the AC joint, and in the biomechanical testing, it was also equal, even higher, resistant to forces that native ligaments can give. If we consider AC joint reconstruction, there's a few points we have to consider. It's anatomical and also reconstructive key points we have to look at. First of all, the AC joint resection or the lateral clavicle resection has been a procedure which has been done in the past a lot, and this is a very interesting study who investigated how much we can really remove from the AC joint. You can see here the 5 millimeter is the cutoff point where you increase horizontal instability with lateral clavicle resection. So you also should avoid to resect more than 5 millimeters, even if you only do AC joint resection or lateral clavicle resection in an atrophic AC joint. Keep in mind, once you resect more than 5 millimeter, you will get an increased horizontal instability. Then we have to ask about the anatomical variations. As you can see here on the right, not every clavicle is the same. We have the different shapes. And someone can argue that if you use this clavicle and you over-reduce the clavicle, you will generate higher pressures, or you will even create arthrosis in this with osteolysis in the AC joint. And we investigated this with the different modifications on the AC joint. We used an anatomic reconstruction, we used an over-reduced reconstruction, and we used reconstruction which is more than 3 millimeters above the joint line. And within the anatomic position, which would be 0 to -3 millimeter, it doesn't matter which joint line you have, it does not increase in the AC joint pressure. So this is very important because you don't need really to address the different joint configurations. If you look at the fixation points of the clavicle compared to the coracoid process, these are the anatomic insertions of the conoid and the trapezoid ligament on the clavicle. And this one here is a bone mineral density measurement. And you can see here the density is highest in between the attachment points of the conoid and the conoid and the trapezoid ligament. So if you want to repair or drill anything, we recommend to do it within this range from 25 to about 45 millimeters. If you look at the anatomy of the acromion, which would be the counterpart of the study before, we also looked at the bone mineral density of the acromion. And as you can see here, the density increases from lateral to medial. So we have the medial part of the acromion, as you can see on the right side, with the highest density. And as you look here on the measurements, the thickest part of the acromion would be also the medial part. So if you do any additional surgical procedure, for example, a cerclage or refixation of this capsule, it's best to do it in the posterior medial part of the acromion because you have the strongest bone in this part. And in the last, it has been published a lot about biomechanical studies. We know the different tension suspension implants. We have suture implants. We have grafts we use as the American most do with the anatomic coracoid ligament reconstruction. But all these biomechanical studies show that we can achieve good clinical, good biomechanical results compared to the native AC joint. What's new in the last years, this is a study by Felix Dirner in 2018, is the application of the AC cerclage. This is a very interesting study. At the end, it doesn't matter which kind of configuration basically use. It is always important to at least use the stabilization of the AC capsule. But this is for the translation, the rotational stability remained partially reconstructed. So if you have a high-grade AC joint dislocation, I really recommend to also address the AC joint using a cerclage, whatever material implant you're using. So this is a technique of choice. This is one which has been published in 2015. Of course, we have also adapted our techniques. In the years we used here a PDS implant to do the AC cerclage. Now we changed to other kind of wires. And this is an arthroscopic assisted technique, which is also an atomic technique. So basically we reconstruct the AC joint using these cortical buttons on the top and on the base of the coracoid with some sutures in between to reduce. And then we also address the AC capsule using a cerclage. As I mentioned before, it doesn't matter what kind of cerclage, at least you have to do and add one cerclage. And also the clinical results show that we have to add the AC cerclage because in this study from 116 patients, which has been done by the French group, they saw that the AC dislocation requires stabilization in both planes, and the coracoid stabilization alone is not sufficient, regardless of type of implant used in this study. So also this one here now underlines the clinical importance of addressing the AC capsule. This one here is an interesting study, a clinical study from the group of Markus Scheibel in Berlin and Zurich. They investigated the clinical outcomes of the over-reduction, and they concluded and proposed to over-reduce the AC joint because it may lead to a favorable radiological result, and because of its association with superior radiograph outcomes, consideration should also be given to use the additional AC cerclage. So also this clinical study supports the use of the AC joint cerclage by little over reduction, as you can see here, A, B, and C. This is the over reduction, this is the anatomic, and here's a little displaced. And type A is the one which is recommended by this group. Also, we investigated our patients that we treated with the arthroscopic assisted CC reconstruction, and we compared the CC reconstruction only versus CC reconstruction with an additional AC cerclage. We followed these patients for 2 years. Both groups, I have to say, have good clinical outcomes, but the AC distance increased in both groups from the post-surgical measurements to the 2-year follow-up, but we have to say they were generally lower with the additional AC cerclage. Also, this points out that this one is a necessary step to do. So to summarize this presentation and the take-home measures, so the proper radiographic assessment is a very, very essential thing to do to get the right diagnosis. So I always recommend the panorama view and the Alexander view, the stress view of the dislocated AC joint. You always have to respect the anatomy, as I already mentioned, with the different data we have about the bone mineral density. You also always should consider CC and AC reconstruction, whether which implant you use, it's up to you. If you do it arthroscopically or open, it has shown that the arthroscopical assisted also helps to identify concomitant glandular lesions, which we have in up to 17% of AC joint dislocations. And we also know that the anatomic reconstructions show better results compared to the non-anatomic reconstructions. So at this point, I'd like to finish my presentation, and hopefully there are no questions remained after the presentation regarding AC joint dislocations. So my lesson learned is it is not the strongest of the species that survives, nor the most intelligent, but the ones the most responsive to change. So I'm hopefully had the possibility to give you some thoughts about AC joint, and maybe someone will change his practice. Thank you.
Thank you very much, Andreas, for that fantastic presentation. A huge overview into all the recent research as well. Couple of questions, Andreas.
Yeah, of course.
Yeah, so when you see, the biggest problem in an AC joint is differentiating between a type 3 and a type 5, isn't it?
Yeah.
And see, normally we take the anteroposterior view. So do you think that always you make a decision based on the Zanka view, that is a 10 degree or 20 degree upward tilt view? Do you think it's important? Because in one of the present slides, you mentioned that initial AP view looked grossly displaced, but when you took a Zanka view, it was reasonably okay.
Basically, my personal decision for surgical only basis on the Alexander view. Once you have an overriding clavicle, I don't really care about the Zanka view or the AP, because this gives me a true horizontal instability, and that will be the indication for surgery. So, for example, the colleagues in the University Hospital in Switzerland, Zurich, they only do an Alexander view because this will be the only X-ray for the decision making. So once you have a panoramic view or you have an axillary view, at the end, this is the only one which gives you the possibility to say, okay, now we go for surgery.
So when you mention Alexander view, it means the stress views, right?
Yeah. So basically, you put your arm, you do an AB abduction, and then you do a scapular view, and yet you see the overriding of the clavicle, which tells you that the AC capsule has to be disrupted.
Thank you, Andreas, for that. And in your slide, one of your slides, you mentioned that when you took a survey among the German orthopedic departments, like the type 3 was the most controversial, right?
Yeah.
So can we make a decision, say, for example, if it's a non-dominant hand and someone is not a laborer, we can offer a conservative treatment. And if it's on the dominant hand, and if it's a manual laborer, can we think that a surgical option would be better for them?
First of all, this study was done in, I think, 2012, so it's long ago. So in the last 9 years, has been a lot of studies about the AC joint and radiographs. So I think some of these orthopedic journals might change their minds after the recent literature, but I totally agree. Like the type 3 is something really to discuss. But also, if you have a type 3 with a panoramic view, with you have almost no high dislocation, but once you do the stress view and you see this overriding of clavicle, this one would be more patient. I would opt for surgery. And then also you have always to consider if it's a highly sportive, active patient, if it's one who only sits at the computer and doesn't really care. So I think there's nothing you can put over every patient. I think it's really something which have to be considered from patient to patient. Thank you, Andreas, for that. Just one last question before we wind up the session. Almost 10 years ago, there was a huge impact for this particular implant called the hook plate, right? So off late, I mean, most of the trend is towards arthroscopic clavicular stabilization with the dog button or whatever, suspensory fixation. So what is the current standing for the hook plate? Well, don't understand me wrong. The hook plate is still something which a lot of people are using, even here in Germany. But most of the time, it is used by trauma surgeons. And since we have orthopedic surgeons and trauma surgeons, and then we have the specialized shoulder surgeons, these group tend to go to the arthroscopic assisted or these low profile implants. But there's still a lot of trauma surgeons which use the hook plate. First of all, the hook plate is a really big incision. Like you have to pull this in here. Sometimes it don't fit. Then you have the osteolysis of the acromion. If it stays too long, then you need a second surgery. And so it is not so controversial or not so. It is a simple surgery. Just cut it open and put the plate in. But first of all, you need a second surgery. And as I mentioned, up to 17% of all AC joint dislocations, you also have glenohumeral problems like slap lesions, labral lesions, which you cannot address with an open surgery. So, well,
so
I think,
yeah, and from what you said, it would be like if you look at the survey which takes trauma surgeons, they would all prefer the hook plate. And if you look at specialized shoulder surgeons who do a lot of shoulder arthroscopy, they would prefer something like a suspensory or a dog button kind of fixation, isn't it?
Yeah, I totally agree. And it's also an age-related, I think, problem. So the older the surgeon, the more the hook plate, and vice versa.
Thank you, Andreas. I think that's all the questions that we have for this session. Andreas, thank you for the fantastic lecture, and I'm sure this is going to benefit a lot of people all over the world. Thank you so much.
Thank you very much for having me.
Bye-bye.
You're welcome. Bye-bye.